I know when I was first diagnosed, I had no idea that ITP was even a thing. I didn't know what a platelet was. For me in Queensland, ITP were the income tax professionals. So it's just what are you talking about? So especially when you're newly diagnosed, it's this snowball, very fast downward slide of education. And we've got some tools and resources and some support for you to navigate through it. Welcome to Beyond the Count. I'm founder and CEO of ITP Australia and New Zealand and your host, Danielle Boyle. This is a space created for the ITP community by the ITP community, where we share real stories, expert insights and everything in between. Whether you're living with immune thrombocytopenia, supporting someone who is, or just curious about what life looks like beyond the bruises and the blood tests, you're in the right place. So whether you're driving, out for a walk, folding the laundry, or just sitting back and tuning in, let's dive in and go beyond the count. In this episode of Beyond the Count, I'm joined by Dr Sara Ng, consultant haematologist at Liverpool Hospital and one of our medical advisors for ITP Australia and New Zealand. Together, we break down the basics of immune thrombocytopenia in clear, simple terms, from what do platelets actually do to how ITP is diagnosed and the symptoms patients may experience. This episode is designed to help newly diagnosed patients and families feel more confident in understanding the condition and navigating their care. Let's get started. Joining me today is Sarah, one of our medical advisors for ITP Australia and New Zealand. Thank you for joining us on Beyond the Count.
Hello, thanks for having me.
And thank you for joining us to talk about, I suppose, the really basic general information about ITP and a lot of the questions that newly diagnosed patients ask themselves or ask their doctor or whoever's diagnosing them, a lot of these questions. So thank you for joining us to help answer some of these really important questions for us today.
I'll try my best.
Wonderful, wonderful. Now, touching on that, for someone newly diagnosed, how would you explain what ITP is in really simple terms?
So let's just start with the term first. So ITP stands for immune thrombocytopenia. It's been previously called a few different things, immune thrombocytopenic purpura, idiopathic thrombocytopenic purpura, just some really big mouthfuls. But in the essence of it, immune obviously means it's related to the immune system and thrombocytopenia means low platelet counts. So it is a rare autoimmune condition where patients present with low platelet counts.
Wonderful. So what's happening with the immune system? Why is this happening? Do we even know why this is happening?
I mean, we'd like to know, then we'll fix it and then it'll never happen again, really, right? In a way, we think that the immune system's gone haywire a little bit. It's like all autoimmune diseases, it fails to recognize what is self. So instead of, being tolerant of yourself, it is now attacking the platelets, thinking that they're foreign. And that's essentially what the immune system does, gets rid of things that are not your own. And this is what's happening in ITP.
So let's go back to even one step before that. What is a platelet?
A platelet is little cells in your blood that do a lot of things, but the main thing it does, it actually helps the blood clot. So if you can imagine, if you don't have enough of these platelets, the consequence of that is you're unable to clot, which places you at higher risk of bleeding.
And prolonged bleeding as well. So I remember after being newly diagnosed, I had a paper cut that lasted for a couple of days because I didn't have enough platelets for that paper cut to stop bleeding. I was getting some really funny looks from a lot of clients sitting there in meetings, etc., with a tissue wrapped over my finger at the time. But what are some of the other, I suppose, symptoms with ITP or with a low platelet count?
I mean, like I said, platelets have a lot of roles. It does play a role in wound healing and forms that initial mesh where, collagen and everything needs to stick to for you to actually have a plug, so to speak. So maybe that's why your paper cut wasn't healing then. So, other causes, if your blood doesn't clot properly, then you're more likely to get bruising. The funniest thing that people don't really realise, I guess, is that people get really tired when their platelet counts are low.
Yeah, fatigue is a huge element of ITP. While it's not a physical symptom, it can definitely develop into something that will impact patients and can impact patients. And I think that it was really heavily raised during the IWISH study, which, you can go back and have a look at the details for the original study. It showed that patients really experienced a lot of fatigue, but clinicians, I suppose it wasn't necessarily as recognised, 5-6 years ago, whereas that has really changed quite substantially.
I think it's important we ask the right questions, which is not always the case.
Exactly. And even with the fatigue, there's also that cognitive function as well, reduced cognitive
the brain
function.
fog.
Yes.
No joke.
I describe it as scrambled eggs sitting in my head and I just can't focus. Okay, so going back to being newly diagnosed, how is ITP usually diagnosed and what are the general tests that are normally involved when you're sort of starting to investigate ITP specifically?
So there's two scenarios where a patient would come to attention with ITP. First is they've come in with symptoms of having a low platelet count, so either bleeding, bruising, or it's on a routine blood test that they've had with their GP with no symptoms whatsoever. Generally, on the full blood count, only the platelet count is low. So your hemoglobin, which is a measure of your red cells and the hemoglobin that they're carrying, as well as the white cells, are normal. It's an isolated platelet count that is low. What we generally do is have a look at your previous counts. Doesn't help if this is your first blood test, obviously.
Yeah.
But if you've had a previous platelet count, if you've got ITP, your previous platelet count should be normal, or you would have had a normal platelet count before, because we know this is an acquired condition. It's something you've developed later on in life. It's not something you were born with.
Yeah.
So that usually helps. So, there are conditions such as inherited conditions where patients can have low platelet counts, and this generally runs in families. So even if this is your first platelet count, you can ask if mum or dad or your siblings have a low platelet count. That
Aunties
also
and
helps
uncles.
as well. Yes, aunties and uncles, all of them, grandparents. And then after that, that's when we go into the rest of the medical history in terms of, other medical conditions that you might have, as well as any new medications that you might have started.
Yeah. So in saying that, so what are the other blood tests, I suppose, and what tests do you perform when going through that diagnostic process?
So platelet counts can be low in a number of other medical conditions. So if people have liver conditions, so chronic liver disease or any kidney problems, the platelet count can also be low. So we generally do liver function tests as well as renal function tests. And we also check the clotting system. So if there is evidence of widespread activation of your clotting system, the platelets will also be consumed. So we want to rule out that there's no activation of the clotting system at the same time. Because it is associated with immune problems, we also check autoimmune serology. So there are certain blood tests that we can do to look for conditions such as rheumatoid arthritis, lupus, and vasculitis. As well as anything else to suggest that maybe the bone marrow is not working the way it's supposed to is something we should look for as well. So generally you would see that in the full blood count. So if the bone marrow is not working, the red cells, the white cells, and the platelets will be low. There might be an increase in a different type of blood cell that shouldn't be there. We also check any viruses that might cause ITP. So there's a few conditions that have been associated with ITP, such as hepatitis, HIV, something called H. pylori that's very common in Asians, where you get ulcers. And, depending on what is found, we then go on to do more blood tests. So, that's where, your bone marrow biopsies come in. Further antibody tests related to platelet antibodies are done as well.
Yeah. How often do you do a bone marrow biopsy or aspiration personally? I
rarely do these now. If it's clearly ITP and you're not suspecting anything else, most of the guidelines say we don't need to do one at diagnoses. Like I said, if there's any other counts that are low, or you've got symptoms that the patient's told you to suggest that there's something else going on, that's when you'll be doing a bone marrow biopsy or some CT scans to make sure you're not missing anything.
Yeah. And that's good to know too, because we don't want to freak anyone out about the diagnostic process. And just because you have ITP doesn't mean you're definitely going to go down this diagnostic path as well, which I think is really important. And that's the other thing that we need to remember as well, is that ITP is a process of elimination and it's a process of exclusion. There is no definitive test to say that this is definitely ITP because we don't have a test.
There's no specific test. Like you said, it's a diagnosis of exclusion. We want to make sure it's nothing else before we call it ITP. And sometimes having a trial of treatment can confirm the diagnosis. And although, most of us don't use a bone marrow upfront, if patients fail to respond to standard treatment, we will sometimes go back and do a bone marrow biopsy to make sure we haven't missed something.
Yeah. And that's good to know as well, which is wonderful.
I guess when I think of a low platelet count, when I have to consult on low platelet count, I either think of it as a production problem or a destruction problem.
Yeah.
Okay. So a destruction problem is obviously something like ITP, where your body's making, hopefully, normal amounts of platelets, and then they don't live as long as they should. And so when you go and sample the total number of platelets, they're lower than they should be because they're getting destroyed.
Yeah.
There are some other conditions where platelets get destroyed, such as clotting disorders, such as things called DIC, where there's a widespread activation of the clotting system and they're all used up. And then you go to the other side, which is the reduced production of platelets. So instead of making platelets, the body's unable to make platelets, either because they're busy making something else, or they don't have the machinery to make the platelets, i.e., the vitamins that you're supposed to have to make these platelets you're not consuming or, you're not absorbing. So, that's where your conditions such as leukemia, lymphoma, they're taking up the space in the bone marrow and you're too busy making those cells instead of making platelets and the other cells. So generally those conditions are the ones where, it's not only the platelet count that's low, the red cells are low as well and the white cells are low because, like I said, the factory's been hijacked.
Yeah. So when we talk about a normal platelet count, can you remind everybody what a normal platelet count is?
This varies from laboratory to laboratory, but generally it's about 150 to 400, give or take. That's a normal platelet count for adults.
Mm-hmm. And people with ITP, like I know what my general sort of number is, platelet count is. I normally sort of hover between 30 and 60 on a good scale. So where would, ITP patients generally sit?
So it really depends.
Let's remove the word generally because everybody is.
Yeah, everyone's different. I think it's more about how severe the ITP is. I think will probably be the cutoff. So anything that's less than normal, but generally less than 100, you're falling into ITP territory. Anything less than 20, we'll be calling severe ITP, mainly because that's when people start presenting with symptoms related to unexplained bleeding and bruising. But in saying that, there's a lot of patients who have ITP whose platelet count's less than 20 and they don't actually have any symptoms besides, fatigue, unfortunately.
Yes. Yeah, exactly. Yeah. So we're talking on, I suppose, the platelet count and the type of ITP. Can you tell us about the different phases of ITP and, what does it mean specifically for patients?
So the different phases of ITP points at the time elapsed. So how much time has gone by since the diagnosis. So newly diagnosed ITP is up to 3 months since you were diagnosed with ITP. Persistent ITP points to the patients who have low platelet counts from 3 to 12 months since diagnosis. And then those who have chronic ITP are the ones who have had, ITP for more than 12 months, essentially.
Yeah. I know that as somebody living with ITP and chronic ITP now for more than 10 years, I don't, I suppose, let it get to me as I don't heavily focus on it as much as I did, especially in those early periods. And it's something that we need to remember as well as patients and the longer you have ITP, the quicker you sort of get there is that, okay, this is it. This is my thing. This is part of who I am, and I've just got to sort of live my life and have the ongoing management, be safe and look after myself. But it doesn't stop you from doing a lot of things, especially if you're not actively bleeding. And it's something that I suppose that we look at the platelet count so often, especially when we're newly diagnosed, looking at the whole person, including the fatigue, the bleeding, I think is extremely important as well.
It's funny. I mean, everyone gets to that phase a bit differently. Mm-hmm. So it's almost like coming to peace with your diagnosis, right? Because you know that the first, that newly diagnosed period, they either don't understand what's happening because they're like, well, I'm otherwise well, I don't need anything. Yeah. Or they're like, or they stress out about the platelet count, even though they have no symptoms. Yeah. And, a lot of them will get hung up on how they respond to treatment or whether or not they need treatment. Some of them live with some of them are more happy to just accept, okay, this is part of me now. I don't actually want to take any medication that's going to make me feel worse if it's not going to change the long-term outcome. Yeah. Whereas others are like, I really want it back to the normal range. I'm like, but that doesn't change anything for you, And less than 100 and 100 is the same, really.
Well, and what is your normal? So my normal may be, is between that 30 and 60 range while on treatment. I am personally a bit of a bleeder myself. So, and that's a decision that, my healthcare team and I made that, okay, I would go on treatment. So I could travel internationally. So I could work full time and have the reduced fatigue and those elements. But that was a decision that I could only make with my healthcare team and my support crew. And everybody's decision is vastly different, and their journey is different, and their goals are different as well.
Yeah, I think that requires the patient to have like a good understanding of their condition and have a trusting relationship with their treating doctors to do that. And unfortunately, I don't think a lot of patients actually get there until way down the track, unfortunately.
Yeah. Yeah. And if you are struggling with those sorts of things, feel free to reach out to us as well, because we can definitely help you navigate that path. Like I said, I've been living with it for more than 10 years. A lot of our volunteers are ITP patients or people, they have people in their family that have been living with ITP for decades. We've got some experience. We sort of know where you're coming from. We sort of get it.
It all comes down to experience, doesn't it? I mean, it
really does.
Who's lived with it and knows what their condition is like, and people should not worry until they're worried. Yeah. And then you've got other clinicians who don't treat a lot of ITP, who panic about a slight drop in platelet count, which we would otherwise tolerate in someone that we know has chronic ITP.
Yeah. So if you do need support, feel free to reach out to us when you do need it.
Thanks to our sponsor Sobi for their ongoing support of ITP Australia and New Zealand and our podcast Beyond the Count.
Going back to talking about the particular symptoms of ITP or the side effects of the different treatments, and, the list is a mile long. An absolute mile long. Let's start, I suppose, with the common symptoms of ITP. You touched on, easy bruising and, fatigue. What are some of the other ones?
So I guess, when you tell patients like, you might get some bleeding, their first question is, what type of bleeding? And you're like, well, it can range from like nosebleeds, gum bleeds, better the bleeding we can see than the bleeding we can't, which is what the patients generally care about. They're like, what if I have, bleed in my brain or like in my tummy? How would I know? And I'm like, they're pretty tight spaces. If you did have a bleed there, you'll know. Yeah. As much as we want to say, these nosebleeds and the gum bleeds don't matter, but they actually do. I mean, people can't do the usual things that they do. I've got a young girl who whenever she drops a platelet count, she just has so much gum bleeding. All her lips are bleeding. Like she just can't do anything. She can't eat. They're, more than just nuisances for some of these patients. Yeah. And the one that I really get really worked up about is like women in particular who have heavy menstrual bleeding related to low platelet counts. And it just gets swept to the side. People are just like, you're just having a heavy period. I'm like, yes, but like you haven't had a heavy period. You don't know what a heavy period is, how debilitating it can be. Yeah. And the sad thing is some of these women don't understand that it's not normal to bleed so heavy as well. I think that's the really sad thing, that, you need to show them what's actually normal, what's normal for them, what's normal for other people compared to them as well, rather than just accepting that, it's just them. Because sometimes it's not just them.
Yeah. And the other thing too, and especially when it comes to heavy menstrual bleeding as well, like there's other, compounding issues when it comes to that. It's like low iron levels, which could be contributing to fatigue levels, and all of these other elements that's a bit of a flag for, have we checked your ferritin levels? These sorts of things as well. So personally, I used to invest in an iron infusion every 12 to 18 months because, again, we're talking about ranges, about platelet counts, but for a ferritin level, my range was within the normal range, but it had started to severely impact my output and my ability to work. So my GP and I had an agreement that if it got to this particular level, let's go with the iron infusion straight away to stop me from getting to the low level
before
and then having to deal with all the complications that go with that as well, like thinning hair and easily distracted, and I'm an easily distracted kind of person anyway. Yeah. So can you imagine?
With iron is so bad.
Exactly. There's so many other compounding factors. So it's something to, I suppose, really communicate. Even if you think it doesn't relate, communicate with your healthcare professional, because they're looking at things from a much bigger picture. So we've touched on some of the common symptoms. If you have someone that was newly diagnosed with ITP who were actively bleeding, what is the first treatment that you generally go with?
If they're actively bleeding?
Yes.
They're generally in hospital.
Yeah.
And depending on where they're bleeding from, my first go-to either be steroids or IVIG with a platelet transfusion, which we don't normally do in ITP. But if you're actively bleeding, we would be considering some platelets just to top you up, just to seal the holes, so to speak.
Yeah. Exactly. And, with some of those treatment side effects can be quite debilitating as well. So
yeah, I mean, with steroids particularly, we always talk to the patient about what side effects are expected. And most of the time, I'm not sure we all really understand how much it is until you have to take it yourself. Mm-hmm. I think that's the thing, right? We can say, oh, yeah, it's going to play with your mood a little bit. And you've got people who are aggressive or start yelling with their partners when they otherwise wouldn't.
Yeah.
So the mood changes are quite significant for some patients. I had a little old lady who basically had a course of steroids and then went out and spent a lot of money buying Apple Watches for her whole family.
Oh, wow.
So she saw me a week later. She goes, oh, you won't believe what I did. So, and then, people can't sleep. So there's a lot of people who get really irritable because they can't sleep. And just going to make sure they're actually taking their steroids in the morning as we've instructed them. I have a few who think that they can just take it at the end of the day. And you're like, well, maybe that's why you're not sleeping. Yeah, because there's otherwise people who have never taken any drugs before. So I don't think they really realize that, there are some things some instructions you need to have with certain medications and certain side effects. So, a lot of them, I have a lot of female patients and some male patients who are worried about the weight gain that they get from steroids. And that's part of the reason why we try to limit steroids use to the shortest period of time that we can at the lowest dose that we can get a response for, mainly because, there are other metabolic side effects that you can get with steroid use. And unfortunately, some of these other metabolic side effects include bone problems. So people get thin bones. I had a young man recently who has thinning of the bone in his hips. And, he might actually need a hip replacement soon because he's got avascular necrosis. So, all these things that they're not as benign and harmless as we think they are.
Yeah.
Because it's so easy for us to write a script and you're just like, well, actually, what are we actually putting these patients through?
Yeah. Yeah. And you touched on IVIG there as well. So IVIG is used in, it has to be used in quite extreme and emergency cases and even pre-op and, those sorts of things as well to help boost those platelet counts quite quickly. Yeah, but again, they come with their own, side effects like headaches and flu-like symptoms, and even some patients experience fatigue or even reactions to IVIG as well.
Yeah, I mean, we're really lucky in Australia. I mean, we have a very controlled process with blood donation. I mean, IVIG, for those who are not familiar with it, is intravenous immunoglobulins. So essentially you're getting antibodies from donor plasma, which helps, boost platelet counts in patients with ITP. And like you said, people do get infusion reactions to it because it's not your own. No. And the additives that they've put in there to make sure it's safe, that that you don't get any other viruses, can sometimes cause these flu-like symptoms, which is not very nice at all. I mean, it's a very good treatment to use, but like you said, we try to reserve it for cases where we need to increase the platelet count quite quickly. For these reasons.
And then post that, you've got your thrombopoietin receptor agonists, or the TPOs, as we sort of nickname them, to help boost platelet counts. But they also, again, come with their own, side effects as well. So, there's three different. There's Remimpelston or Nplate, Avatrombopag or Doptelet, or L-Trombopag, which is Revelade here in Australia. So, these all come with their own box and dice. They all come with their own positives, but also negatives as well. So tell us some of the I suppose some of the symptoms and some of the side effects of these treatments.
I think the main thing is that, I think the landscape's changed so much now that we have a few to choose from. I remember when we first started, we only had L-Trombopag and Romiplostim. I mean, like you said, we have three now. How we use them is also dependent on patients' lifestyle choices as well, not just the side effect profile. But the most common side effects that people do notice is that people do get some liver derangement. Other common side effects include clotting risk associated with TPO-RAs. So, if you have a history of clotting, we probably steer away from these unless we really, really needed to. And because we don't want to give you a clot only to have to give you blood thinners, which would be very counterintuitive. But I guess I think it's not just the treatment side effects that help us pick which ones we want, that patients might want to use. So, circumstances where some patients don't like taking tablets or they don't like injections. So if you don't like injections, then, you're going to be picking either L-Trombopag or Avatrombopag. L-Trombopag obviously comes with its dietary restrictions, so you can't eat for a few hours before and after. And I mean, there was an era of where patients stopped responding to the L-Trombopag because a lot of them were using Ozempic. And Ozempic reduced the gastric emptying time. So then the time where, you needed to stop food before you took your tablet was much longer. And so people are not absorbing the L-Trombopag because of this reason. And so hopefully, those patients could go on Avatrombopag. But as you know, there's a little bit of a lactose in Avatrombopag.
There is lactose intolerant.
So if you're lactose intolerant, that does not help as well. And then, so that might be the patient that you need to put on Nplate. And then, if you're okay to inject yourself, that's good. You can do it once a week yourself, mix it up. But if you can't inject yourself, then that's an extra appointment every week that you're going to find a nurse or a doctor or the hospital to inject for you. So, there's little things like that. One of the rarer side effects with the TPO-RAs is because it is almost like a growth agent telling the bone marrow to make more cells. We've had a few patients where they make too many cells in response to the TPO-RA. So not just too many platelets, but too many white cells and red cells, and a little bit of scarring in the bone marrow, essentially something we call immune myelofibrosis. But this generally, all goes away once you stop the TPO-RA.
It's not a permanent element.
No.
And, I've personally safely been on a TPO now for 10 years. Guys, everybody jump onto the itpanz.org.au website as well. So if you do want information on any of these treatments, whether your doctor has spoken to you about them or that you want to do some of your own research, we do have downloadable treatment information sheets about all of these treatments, including, the pros and the cons, all been reviewed by medical advisors as well. So jump on and have a look at those treatment information sheets so you can do some homework as well.
So I guess no treatments without side effects. And I think the main thing is that, we do try and wean back treatment if it's not necessary. Just because you've started TPO-RAs, it doesn't mean you need to be on them long term or maybe not at that dose. So, you know, there's a process of weaning. If you've been stable, you know, you would try and take the opportunity to, you know, cut the dose down or the frequency down as well. So then you're still getting the benefit with less of the risk. And, you know, same things with steroids. You know, we're going to try to use the least amount for the shortest period of time possible.
Yeah. And a lot of patients, like I've seen over the last, you know, decade or so, can go into a form of remission after, you know, some of these treatments like the TPOs. One treatment we haven't spoken about was rituximab, you know. So a lot of patients can actually go into remission and be without treatment and symptoms and side effects for, you know, a substantial amount of time. So, and in saying that, there are a lot more treatments coming down the pipeline that we think that may be able to provide that sort of hope as well for patients too.
I'm sure you'll have a whole separate episode on upcoming treatments. There's some very good ones at the moment.
Different episodes just on clinical trials and the That's so many,
it's so exciting.
Yeah, so many options. So when you do diagnose a patient with ITP, and how do you reassure them? How do you let them know that they're not alone and they're going to be okay, and you know they've got some support around them?
This is, I think it's very situation dependent, but where the haematology clinics are generally in the cancer centre of the hospital, the first thing you say, you know what, it's not cancer. Everyone just breathe.
It's not cancer.
And then you're going to hear that audible sigh and you're like, oh, thank God. And you're like, okay, so what is it? And so I think the main thing is, you know, you just have to tell them like, you know, the same, we've just been telling them it is an autoimmune condition.
Yeah.
And your platelets are low, but you have plenty of them. Generally, people have them in excess. And unless they drop to below a certain level or you're getting symptoms, we generally don't have to do anything about it. There are situations where, you know, platelet count needs to be a bit higher, say for surgery, or you're more likely to bleed at a different level compared to other people, then we would do some treatment. But most of the time, people with ITP are untreated, they're living life as usual, and then, you know, they just keep an eye on things once in a while. They might make, you know, some more discussions. You might have to see a few more people if you have any other medical problems, just to take this into consideration. But most of the time, you know, people are well.
Yeah, they truly are. You don't look sick. Is generally one of the statements that I suppose an ITP patient will get. But
I don't think that's very fair. Like, I mean, you know, a lot of people don't look sick. Just because you look good doesn't mean you don't look sick.
Yes, exactly.
You handle it well. That's the kudos to you. It's not.
Oh, you would never know.
Oh, thanks. Well, thank you.
If you get the side, it's very complex, but thank you. But yeah, at the end of the day, I think that we want patients to know that, you know, we've got this wealth of knowledge in you guys, our medical advisors, who are, you know, leading the way on clinical trials and, you know, informing and educating, you know, the non-special ITP specialists in Australia and New Zealand. And, you know, you guys are reviewing all of the information that we put out there as well. But if you want to talk to someone that sort of gets it, you know, feel free to pick up the phone or shoot us an email or jump on WhatsApp or whatever and have a chat. You know, we are around more often than not. You know, sometimes patients at, you know, midnight, they need that support, and, you know, we're there to help them as well.
I don't think you should sell yourself short. I think you guys do a lot at ITP Australia, New Zealand, in raising awareness, you know, providing patients with information that they can actually understand. I think that's a really big thing for people to understand their condition before they can even talk about it or find someone to talk about it. It's a good place to start.
Yeah, it's a really good place to start. And, you know, that website again, everyone, itpanz.org.au. Yes, shameless plugs all the time. And I'm not above it. I'm definitely not above it. Thank you so much for joining us. I've absolutely loved our chat. I've loved our discussion, as always. And thank you for helping to, you know, just shine a spotlight and give the basics ITP for dummies version maybe. But it's not, I wouldn't say that it's for dummies though. Like I know when I was first diagnosed, I had no idea that ITP was even a thing. I didn't know what a platelet was. For me in Queensland, ITP were the income tax professionals. So like it's just sitting there in emergency and, oh, you've got ITP. It's like, no, they do tax. That's not real. Like, what are you talking about? So it is especially when you're newly diagnosed, it's this snowball, very fast downward slide of education. And hopefully we've got some tools and resources and some support for you to navigate through it. So thank you very much for joining us and for helping to educate some of our newly diagnosed audience members.
Thank you for having me.
I hope you all got a lot out of today's episode. Before we wrap up, here are 4 key takeaways from our conversation with Sarah. Number 1, ITP is an autoimmune condition. The immune system mistakenly attacks platelets, leading to low counts and increasing risk of bruising and bleeding. Number 2, diagnosis is often one of exclusion. There are many reasons why you would have a low platelet count. During diagnosis, doctors will rule out other causes of low platelets, including family history, infections, medications, or blood cancers before confirming immune thrombocytopenia. Number 3, ITP has different phases. There's the acute or newly diagnosed for people up to 3 months since diagnosis, persistent ITP for those between 3 and 12 months, and chronic ITP for those who have transitioned past that 12-month period. Each phase influences treatment decisions and monitoring. Number 4, symptoms and side effects vary from person to person. Common symptoms of ITP include bruising, nosebleeds, gum bleeding, heavy menstrual bleeding, and fatigue. Treatments often have their own side effects. Understanding your treatment options and possible side effects through our treatment information sheets can help you make decisions about your care. Lastly, ITP is as individual as you are. There are no 2 cases that are exactly the same, and what works for you may not necessarily work for the next person. This might mean that it takes a little longer to find your new normal, but know that you have the support you need when you need it. A huge thank you to Sarah for joining us on Beyond the Count and helping us understand the basics of immune thrombocytopenia. If you're looking for support, connection or information, visit itpanz.org.au. You'll find The Count, our quarterly magazine, patient stories, treatment information sheets, clinical guidelines and a wide range of resources designed to help you and your family feel informed and supported. Most importantly, you'll know that you're not alone. There's a whole community here just waiting for you. If this episode was helpful, please share it with others in the ITP community and leave us a review on your podcast platform. It helps more people find Beyond the Count. We've got more expert conversations, patient stories and more coming soon. So hit the follow or subscribe button to stay updated. Thanks for listening as we go beyond the count together.